Now, I've been asked to speak about, or rather suggested also to speak about mental health care in Europe. And I do this because I'm worried and I'm unhappy about what I see being proposed as solutions and cures for the disastrous situation that exists in many parts of Europe and by reflection in other parts of the world. I shall, in talking this, first start by saying a few words about the context in which healthcare is functioning today, proceed to say a word about the changes of the morbidity patterns that we are noticing, and then also connected with it, the transformation which we have seen in the functioning of health services, leading you to believe and also to start yourself to examine the priorities which we have set many years ago. Priorities such as, for example, that mental health should be done in primary care, and similar priorities which have been so highly placed as if they were sacred. The context of mental health care is terribly important, and in a Congress of Social Psychiatry, I don't need to say this. There are many external influences that have changed the nature of psychiatry and changed the manner in which it functions. There is first globalization. When I was a younger man and when globalization started to become popular, I was immensely happy that it is happening. I thought, here is finally the world is opening. I spent my youth and first years of my work in a country in which you had to wait for 4 years to get a passport, and you got $10 per year for all your international travel. So that the notion that borders would be open and that people could freely communicate left, right, and center was just unbelievably attractive. It was to an extent, and many borders have been opened, but there have also been negative consequences of globalization for ourselves and for the people of the world. One of them, perhaps, which was brought out so very clearly, is the notion that the globalization was not a traffic in all directions. It was mainly a traffic from north to south. It was mainly a traffic from the richer countries to the poorer countries. It has killed some of the languages which were previously very often used. English has become the world language. That's wonderful, but it has also in process killed some other languages which we liked and which were extremely important and contained a richness and an importance which has no equal. I think that other aspects of globalization have been even more difficult. There was a transfer of value systems from one to another set of countries. We have been, in the globalization, seeing the emphasis on independence and autonomy of the individual, something that was an anathema, an absolute sin for the rest of the world, which believed in interdependence. And nobody is an independent being. All of us should be part of a group in which one helps another, in which one feels well about another, in which one has empathy and sympathy for those who surround you. But autonomy and independence, as one of many values that have been imposed on the world, have been a characteristic of globalization. More primitive consequences of globalization include also the changes that have happened in our understanding of the nature of disease, and I'll come back to that later when I speak about this. A second change of importance in culture has been that culture has horizontalized itself. Previously, you defined the culture by people who lived in the same territory, who shared a number of cultural habits, who shared a number of ways of living and so forth. But in the last 15 or 20 years, maybe more, there has been a horizontalization of culture, in that people have much more in common with people of the same class and same profession in other countries than they have with people of different professions in their own country. That we today understand the doctor in Venezuela much better than we understand the janitor in the house in which we are living. And that has been first seen in a wonderful work that has been done by Muriel Hammett in New York, which have clearly demonstrated that the frequency of diagnosis of schizophrenia grows with the distance in social class between the doctor and the patient. But that is also happening with us today, and we see that in fact the understanding of the language of other classes, language of the elderly or language of the children is becoming unknown to those, and including the psychiatry with whom we are living. Women worldwide are changing their role. This is fabulous. It is fantastic to see that they are coming in all disciplines and professions in most countries of the world. The problem, however, with the changing roles of women is the following. Women traditionally have had to carry the roles of transmission of culture, of care for the sick, of the upbringing of children, of soothing and finding ways of speaking, of building social networks. Tremendous amount of work gone into this and made our societies function. Now came the new openings. Women are allowed to go and work, and in fact they manage to work. They are still not paid as well as other people, but they are still there. At least they're coming out and doing work. But nobody has been thinking of what to do about the other tasks which they also still have. Nobody has gone out and found support for them to be able to do these new duties, but at the same time not perish under the burden which is now becoming very often unbearable, and therefore results in an increased proportion of women who commit suicide, in an increased proportion of women who are in fact falling sick with depression and a variety of other things. Just one of the indicators of that overburdening that has been happening, not least of tremendous importance for psychiatry, because among other things they have been and still are looking after a large proportion of people with mental illness. Now, the word which is on this slide, which is a long word which only an Australian can invent, is the word commoditification. It's a word that describes a strategy and a politic which says that everything is a commodity, like sugar or cotton or wood or timber. Health as well is a commodity. The more you pay, the more you will get. The less you pay, the less you will get. Anything in healthcare is measured or becoming measured by the financial effect. Providing health used to be an ethical imperative for society. It is now becoming an economic opportunity. People ask about hospitals. How well does the hospital work? And the answer is, it makes quite a lot of money. Now, that's not an answer for a hospital. It is a terrible answer for a hospital. Previously, doctors did not care whether they were spending too much money as long as the patient was getting better. Now, they do not care whether the patient is getting worse as long as they make more money, not for themselves necessarily, but for the institutions for which they work. And this commoditification has entered everywhere. It is combined with a variety of changes in the nature of relationship with doctors, between doctors and patients, but also in the nature of thinking about medicine. Medicine as a trade, and we see that it is intruded in what we have, because even the language has changed. We don't speak about patients any longer, it's clients. We don't speak of humane care, we speak of quality assurance. We speak of cost effectiveness. All of these terms are terms of trade. They're not terms of a human discipline in which people want to help each other. Another change that has happened is the change of the middle class. The middle class has been always a carrier of morals of society. It protects the morale. Neither the very poor nor the rich have been particularly interested in keeping the morals going. But this middle class was doing this. And what we are seeing now in the last few years is a continuing deterioration of the middle class in numbers and in their financial and other capacities. Middle class is getting smaller and smaller and smaller and carries more and more burdens. Now it is extremely rare in Europe to see that a single salary will in fact be sufficient, which previously was not the case. My grandfather, who was an engineer, carried for a wife 4 children and 7 undefined relatives who were there in the house for some reasons, we don't know why. But his salary was carrying this. He was a middle-class citizen. That would be unthinkable in current times. And I think that the diminution of the middle class, its extra effort which it has to put, wonderfully summarized in a book that was written by the New York Academy, recommended by the New York Academy of Sciences, which is having the special title Screwed, describing the middle class in general. This weakness of the middle class has consequences in the clear diminution of social capital, trust between people, capacities of many of the things that the middle class in the past has been doing. Finally, there is also the changes of the family structure, a significant one, wonderfully summarized in the words of the Archbishop of Edinburgh, who said, "We are entering into an era of serial monogamy. That is, everybody is married most of the time, but not always with the same person, so that nobody knows anymore who is whose father, mother, child, grandfather, and it becomes quite cumbersome because children of wife number 4 don't want to really look after grandfather of wife number 3 or father of number 4, and it's become a confusing story. You speak to people, children will tell you, this is from my mother, but she's not a wife of my husband, my father, because you get confused by it. But the roles of these people who undoubtedly enjoy serial monogamy have reflections on the upbringing of children and the care for the elderly. An increasing number of countries now have to introduce very strict laws about the obligations of children to look after their elderly parents because they don't do it anymore. And this is true for developed and developing countries, from Switzerland to Bangladesh to Japan to China. In various countries, very big fines if you do not look after. And people pay the fines because they are just usually one person is looking after the elderly, and they are not willing to do this anymore. The age of informatics, there is also a thing that surrounds us all, is, I think I don't need to mention it too much, except to say that it has significantly contributed to a sense of loneliness by a large number of people. In a town like London, 10 or 8 years ago, there was the census showed that 26% of the households are single-person households. And then it was answered in a commentary on that in fact, it doesn't matter very much because they have iPhones and iPads and whatever else. It is undoubtedly true that the exchange of information has been vastly helped. But exchange of information is not equal to human contact. And the fact that we know more doesn't make us feeling any better accepted, doesn't make us feel to be members of anything or anybody. So much about the context in which we are living. Now, morbidity has also changed. Diseases which we are seeing are not longer the diseases which we used to know. First, there is an epidemic of comorbidity. Most of the people over the age of 55 or 60 will in fact have at least 2 diseases, if not more. We know that people with schizophrenia die 10 to 15 years younger than people who are not having schizophrenia, not because of schizophrenia, but mainly because of physical illness, which is not properly looked after and so forth. Practically everywhere, we find that on one hand, you have an increase of the number of people who will live longer, but at the same time also a significant increase of the number of people who suffer from more than one illness. And the tragic fact is the following. Humanity, the world at large, is very proud that it has extended the life expectancy worldwide, fabulously extended, for 20 years or more. But the life expectancy of disease-free years has remained constant. It's not changed so that we live much longer, but we live much longer sick, diseased, disabled. And much of this disability is not only due to the fact that diseases are doing this, but also the fact that somehow our health system is not capable of dealing with more than one disease at a time. And so many of the people who live longer years, they sort of stagger from one life endangering situation to another, surviving, but not really being a healthy and enjoyable life with that. There has also been a change in the nature of diseases which we are seeing. One part of the change undoubtedly is due to the influx of migrants. Migrants all over Europe have brought with them not only foreign food and ways of talking and ways of living, but also changes in diseases. Their diseases have changed as well. In a recent study that has been done in Germany, Turkish doctors who were invited to come and examine Turkish patients in Germany don't know what to do with these diseases. They don't recognize them. These are not the Turkish diseases any longer. They are now diseases which have become Turkish with a German Nachgeschmack, with a German extra touch. And the same is true for the diseases in other parts of the world, which have accepted a little bit of both. People who live in in European countries in general are more and more seeing this change because of an osmosis of culture that is going on, not only in disease, but also in culture in general. It may, of course, be that there is also what the Germans have called in their time a Krankheitswandel, a change of the nature of disease, demonstrated, for example, in the practical disappearance of catatonic schizophrenia, of hebephrenic schizophrenia, which are very rarely seen, which the previous mental hospitals, even when I was there, abounded in people who believed that they are Napoleon and Jesus and I don't know who all not. Now it's quite boring what they are telling you. I mean, they tell you the same thing. It's usually the CIA which is after them, and maybe it is. So it's very difficult to say what in fact, but the whole variety of things that we have seen earlier have certainly gone away. And there is a number of other changes. If you speak to colleagues who have more experience from previous times, many of the diseases that they see today, they do not recognize. They do not quite know where to put them, although they had a lifelong experience of dealing with mental illness. There has also, of course, been a change of relationship between doctors and patients, which is important. Doctors now are much often less knowledgeable about disease than their patients. The patients spend a lot of time thinking about what their disease might be. They have various sources of information. They have also various contacts with people who talk about disease. And I think that the relationship in general has changed, partly because so much insistence has been put on the need to respect the patient, mental or other, but partly also because the patients have grown in their knowledge, self-confidence, in the manner in which they live and work with a doctor. More so, of course, when they are rich. Now, healthcare has therefore also changed. First, there is a huge and massive intrusion of private health care everywhere. If you want to really be treated well, in India, for example, you will go to private healthcare institutions in India. Why? Well, India, which has a lot of people there, 1.3 billion, in fact has about 300 million people in the middle class, well off. Somebody should compare this, an ocean of poverty, with the islands of rich people. But the islands have 300 million, and that, of course, is a territory in which it is worth going in. And so companies, both pharmaceutical but also other health companies, have gone there and established themselves. And the difference between healthcare in the private institutions and that in the public institutions is enormous. And the people in the public institutions are less and less happy to accept what they are getting, not because it is worse than before, but because they see that somebody else is getting so much more. And private health care has also entered in a massive way in European countries, very often hidden from public statistics. The number of people with mental illness who are somewhere in a private institution, which sometimes does not even carry the name of hospital, is quite large. And if you really do a survey, you find them, but you would not see them necessarily. And that changes, of course, to a large extent, the nature of care. It's linked to commoditification. Private health care is after not only providing service, but also making money. And I think it's making money directly in relation to the patients, not via the tax system, which would have perhaps paid them a salary. And while this is happening, and while there is a huge influx of comorbidity, medicine is becoming fragmented. It's falling apart. There are now specialists everywhere. Specialists for the left hand, operations of the fingers, very important specialists. Other specialists who are looking only in a particular thing. And even within our own discipline, there are specialists in early interventions, specialists for manic depressive illness, specialists for schizophrenia, chronic schizophrenia. They don't talk about other things. Anybody comes with anxiety, please go away. I'm not dealing with this. I'm a specialist in late interventions in schizophrenia. If you get that disease, you come and see me again. Unbelievable situation. But that is what is happening. And the more you look at it, the more it will be, not least because also of private health care, because the top specialists in the fragmented medicine can charge much more than you can charge if you're just an ordinary general practitioner, or even worse, an ordinary general psychiatrist. Now, medical ethics has also changed, not only because of this relation with money, but because of other things as well. For example, the relationship to euthanasia has become completely changed. We were previously thinking that this is a rare thing, and mainly left to the conscience of the doctor who treats a patient for many years and has empathy and sympathy for the terrible suffering and does something. Not any longer. Last year, in Belgium, there were 2,300 people who were helped to die. And some of them died for reasons that we would previously not accept it. For example, a lady who was a transgender, who did the necessary operations, but when she found herself in the new, or he found himself in the new situation, she was not very happy because of stigma and everything else what might happen. So she went and said, I'd like to die. And they said, okay, we'll help you. There were two brothers who were not hearing very well from birth, and they got an eye disease which was leading to blindness. So they came and asked to be helped because they cannot live, they said, in darkness and without hearing a thing. So they went and they said, we would like to die, would you help us? And they said, yes, we will. And if you go through the record of who has been all allowed or included in this particular listing of the Belgian assisted dying group, you will see that the concept of helping people to die has significantly enlarged, and that the borders are no longer as strictly placed as we used to have them in my time, when the main tasks of doctors were to save life and diminish pain. Those are the two things that we had to do at all costs. Now, two other things I think which I should like to mention. One is the medical tourism, and the most beautiful example, I have an advertisement which appears in Saudi Arabia. It says, not in Saudi Arabia, in Abu Dhabi. It says, if you have a disease, a mental disease, we can provide you treatment. It's only 12,000 kilometers away. They fly them with an extra aeroplane from Abu Dhabi into Malaysia and provide treatment and return them very well healthy back. All included, first class travel with one family member included. And this medical tourism is a big thing, but is it big only? No. There's a huge number of people who now move. In Geneva, where I live now, there is a very large number of Hungarian dentists who will examine and then invite people to come to Hungary, where they can get dental care for so much less. Psychiatry as well. You want to be treated in where they don't know you? Very well, you cross the border and you are treated in another country. Now, this may be very helpful for the patient and certainly increases the income of doctors in those countries. But what does happen is that our statistics and our knowledge of who is treated for whom, by whom, where, when, and for how long are becoming extremely unreliable. And there is, of course, also sometimes the quality assurance in those medical tourism is not possible. Now, there are indications that healthcare is failing us. One of them is, for example, the appearance of case managers in the United States. Case managers are people who help the patient who has many diseases to get care. It's so complicated to get care that you have to employ an extra person who will guide them by hand from one doctor to another. I mean, that is wrong. You cannot possibly imagine that there will be such people for every single patient who will go around. With the growth of comorbidity, it's going to become extremely complicated. Transinstitutionalization is another phenomenon, another symptom that things don't go well. 70% of people who are now in mental hospitals, who are now in prisons in the United States of America, have a mental disorder that needs treatment and could benefit from treatment. And where did they come from? Most of them from the mental hospitals, which closed their doors. So for a while they tried to live. They didn't get sufficient support in the community, nor from anybody else. Sooner or later, prison at least provides them a roof over their head, some food, and so they end up 70% of these people in debt. The largest mental hospital in the world is the county jail of San Francisco, of Los Angeles. Then there is also a number of diseases which have come or started coming back again. Another sign that something is going wrong, particularly diseases which are preventable, like measles. There have been all over Europe a growth of the number of measles cases because so much of the population has refused vaccination. They don't want to do it. And there are three reasons for it. One, the mothers say, this disease is not very serious, so we don't want it. There's no need to do anything about it. Second reason, we don't believe that this vaccine works, so we don't want to give it. But the third reason is really a symptom of a significant problem in our society. They say, I'm not going to let my child be immunized because other mothers have immunized their children, so my child will not get the disease from them. Relying in a way on other people to do the work for you and refusing to take part in social care for the disease. And then there is a huge queues for alternative medicine. The number of traditional medical doctors in the village of Herisau in Switzerland has now grown to 1,200. In single village, you can go and get any treatment you want, magnetic, or maybe you would like some herbs, or just handing lays, or whatever else. All of it is very available and very present. In France, there are more traditional healers than there are medically qualified persons dealing with healthcare. And in other countries as well. Most of these traditional and alternative practitioners work in parallel with the doctors. And the patients go from one to the other very often. They are attracted to the traditional healers because they are so much better in human relations with them. They listen to them. They would like to hear what these people have. I mean, take this in contrast with the findings of two studies, very recent, that the maximum time that the doctor in a general practice in Europe spends before he interrupts the patient is 25 seconds. 25 seconds after the patient started speaking, he is interrupted because the doctor has a hypothesis of what this could be and follows this hypothesis, not letting the poor. And so the people, knowing that they will not only have more than 25 seconds, they speak very quickly about one particular problem for which they'll get a prescription and go away. Because they see that that is in fact what happens, while the traditional healer sits there and thinks about them with great care for a long time. Now, this means that our priorities should shift a little bit. We have been very concerned that we should have much more everything into community care. But three problems emerge. One, there are no more communities. The communities which were geographically defined in the past don't exist anymore. They've gone. In Argentina, 95% of the population is urban. Most of them have come to town in the last 15 years. Nobody knows anybody else. And the community, as we traditionally defined it, and as we still find it in some parts of Europe, has gone, vanished, disappeared. There's nobody to whom to talk. And the best form of care that we are still able to produce is to treat the person in the community, but not that the community helps us because it's so ill-defined and so often disappearing. Not only that, but many of the people in the community as such will in fact will not want to be treated in their own community, but because of stigma will want to go somewhere else where nobody knows that they are. Nobody wants to know what kind of a disease they have. So we have to think a little bit, is it possible to create what Graham Thornycroft and others have called a balanced care system? I think a book that he and Michele Tansella have published some time ago produced some suggestions in this respect of thinking, how do we provide many different forms of care for many different people that grow and live in our communities? Not saying we must do this for everybody or we must do this for the other. Much of the health care after the Second World War is military health care in which everything is done by averages. But in my life, I've never met an average person. They're all different. They're all different from average. So we should also take this into account in thinking about care. We have fortunately started speaking about recovery instead of rehabilitation because many of our people have never had anything to be rehabilitated in the first place. So to think of ways in which one can make people understand and accept the notion that they must do the best with what they have and that they are not less valuable because of that is something that is a major task, not taught at present in medical schools. Task shifting. We shall pass on the duties of treating mentally ill people to general practitioners. First I mentioned in 1872 by Dr. Ray, who wrote a beautiful paper about this. Subsequently in 1973 by WHO in a wonderful report. 78 repeated and confirmed by the Alma Ata Declaration on Primary Health Care. And since then, we keep talking about it. And the general practitioners in general say, thank you very much. We have enough work as it is. Do not bother us. So we have to think a little bit about which kind of patients are likely to be best treated by people who are in general health care. And who are the general practitioners whom we can train and bring in to be with us and to work together on these patients. So it's a significant change in the original military style. Everybody will go and be treated now. We'll now teach general practitioners about how to handle all of these diseases. It's just a matter of time before we succeed. We have also learned that having a mentally ill person in the community, in the family, means a significantly increased risk of disease for family members. And therefore, gradually, we have to think not of mental disease, but of physical disease, of different types of diseases. So that if we want to maintain the notion of bringing people into the family, we have to think of what are we doing for the family members in terms of health care. What kind of things are we offering them? There is only one paper that I have read giving clear criteria about which families are fit to accept a mentally ill person and which mentally ill people are fit to be discharged, related to this particular fitness of the family. Not very much. We have been often discharging people, which meant a tremendous burden to the family. They've taken it, they worked with it, but in the end they also became very often overburdened, burned out, and a variety of other problems. We've also learned that we should, in fighting stigma, think twice. Maybe remove stigma is a task that will take more time. What we can do now, much more powerfully, is to go after discrimination and try to prevent discrimination which follows stigma. Because that's a task that can be helped by legislation, it can be helped by specific instructions about what should be done, by specific training, and by a variety of other measures. We should also think about education, previously we were saying education of the family is enough. No, it is not. Because for a family of 3 persons who look after a demented father or mother or a severely sick person, somebody has to give up his work. Somebody has to start doing nothing but care for that person. So it's about time that we think of how we can pay a full salary of a person who is in fact looking after the patient in the family. Not the ridiculously small sum like 150 euros per month for somebody who is looking after the patient 24 hours a day for 30 days. We should probably also, while we are doing the deinstitutionalization, not remember that many people are still in institutions, maybe 800,000 in Europe, and that the quality of this care in this institution is often abominable, even in the countries that are most advanced. Yet, the specific attention to the quality of care in every respect, to the number of staff that are given to these hospitals, etc., is very often absent. And you cannot read much about it. There is a shattering report that has come from Russia about the mental hospitals and the state in there. But many of the things that they have described in recent years are also true for many of the hospitals that I have visited in European countries, which are not fit for care nor for human existence. We should also gradually start thinking about primary prevention. Not that we can do it. We cannot do it. Somebody else should be doing it, but with our help and with our instigation. Take the example of iodine deficiency, which is more or less resolved in Europe. But iodine deficiency leads in mothers, in women who are in fertile age, leads to cretinism. Approximately 10 million children with cretinism are born every year. Are we out on the barricades telling people you must put iodine into the salt? I'm always reminded of such specific examples, and there is a large number of examples of primary prevention that we have presented to the World Health Organization. Everybody has accepted it, but nobody is doing it. And therefore, I think we have to think about becoming advocate for preventive measures. Ladies and gentlemen, I think that what I have described should make us think and examine the priorities which we have said and which we have observed and for such a long time considered important. I think it depends on us to do it, and the time to do it is now.